This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Welcome to the deep dive. Today we're venturing into the biliary tract. It's this surprisingly complex network of ducts, tubes, and of course the gallbladder.
Right. It seems small anatomically, but the pathologies here are just huge. We're talking monumental issues, often with immediate risks like infection, or maybe more critically, that long-term cancer potential.
Yeah, it's foundational stuff. For anyone aiming for mastery in advanced internal medicine or gastroenterology, you really can't ignore this area.
Absolutely. Our source material makes it clear disorders here make up about 10% of GI board questions?
That's significant.
It is. But for you, the learner listening in, our mission today is more than just facts. We want to show you the clinical thinking. How do you triage a patient when you find something incidentally? How do these subtle architectural flaws kick off potentially life-threatening processes, often silently?
Exactly. We're aiming to transform this, stack of specialized clinical data, anatomical diagrams, guidelines, intervention studies into knowledge you can actually use. We'll cover the whole range.
Yeah.
From rare developmental disasters, things like cysts and maljunctions.
Which have that high malignant risk.
Right. All the way to the really common metabolic issues like gallstones, and then the immense technical challenges of post-transplant care.
And we'll definitely pay close attention to the guidelines, specifically, the ASGE 2019 framework. It's so critical in deciding when you just watch versus when you absolutely have to intervene aggressively.
Okay, let's dive in. Let's unpack this, starting right at the beginning with the literal architecture itself. Because in the biliary system, if the plumbing isn't perfect, the consequences can be catastrophic.
Right. Before we even talk about diseases, we have to get a handle on the underlying infrastructure. Think of the biliary tract as a drainage network. Understanding the normal anatomy is really the only way you can spot the dangerous variations.
Like having the map before you navigate.
Exactly. Figure 1 in the sources, it shows this huge array of configurations, both normal and abnormal, especially within the liver in the intrahepatic ducts. Having that detailed map in your head is just essential for reading cholangiograms correctly and for planning high-risk procedures like ERCPs safely.
Because if you don't know the blueprint,
you risk serious complications during instrumentation. It's that simple. Hashtag 1.1 pancreatic biliary malfunction PBM.
Okay, let's jump right into one of those architectural flaws, one that carries, as you mentioned, immense malignant risk. Pancreatic biliary malfunction. PBM. What is it about this specific anomaly that makes it so dangerous?
Well, the danger is all in the plumbing configuration. Normally, the common bile duct, the CBD, and the pancreatic duct, the PD, they join inside the wall of the duodenum. This usually creates a short common channel, and it's protected by the sphincter of Oddi.
Okay, standard setup.
Right. But in PBM, they join outside the duodenal wall.
Outside?
Yeah, outside. And this creates an abnormally long common channel. The definition we use is typically greater than 6 millimeters in length.
6 millimeters. So why does that length matter so much? What's the consequence?
That extra length, it creates a mechanical vulnerability. You see, the pancreatic secretions are under high pressure, and they contain these highly proteolytic, potentially carcinogenic enzymes.
Right.
This pressure overcomes the resistance in the bile duct, leading to this continuous severe reflux of pancreatic fluid back up into the biliary tree.
So pancreatic juice is flowing the wrong way into the bile duct.
Exactly. And that reflux is the root cause of the pathology. It leads to chronic, low-grade chemical inflammation, which over time causes changes in the biliary lining metaplate dysplasia.
And that's the pathway to cancer.
That's the pathway. The sources confirm this chronic exposure significantly increases the risk of biliary malignancy.
How significant are we talking? Did this really change the lifetime risk dramatically?
Oh, substantially. It makes PBM something you absolutely have to manage proactively. It dramatically increases the risk of gallbladder cancer. Specifically, this isn't just theoretical. Plus, PBM is often linked with ductal dilation, and it's seen in about, 3/4 of coloductal cyst cases? It shows how these developmental issues are often connected.
So finding PBM isn't just an interesting anatomical variant. It fundamentally changes how you manage the patient.
It absolutely does. Given that huge inherent cancer risk, you have to strongly consider prophylactic cholecystectomy, removing the gallbladder.
Even if the patient has no symptoms at all.
Yes, arguably, especially if they have no symptoms. You're doing the surgery to prevent a future malignancy. And, it's worth noting the reflux isn't always just one way. Bile can also reflux into the pancreatic duct, increasing the risk for recurrent pancreatitis, too.
The sources mention the Comey classification for these junctions. For the learner, why is it practically useful to know if it's a type 1 versus a type 2?
Good question. The Comey classification, shown in Figure 2, it distinguishes types based on the angle they join at and any associated findings. Type 1 is a right angle join. Type 2 is an acute angle. And type 3 involves more complex patterns, often with things like pancreas divisum.
And why does that angle matter to, say, a surgeon?
For the surgeon, knowing the angle and any other anomalies helps plan the corrective procedure, especially if they need to excise a dilated duct and then reconstruct the drainage, maybe with a hepatochogenostomy. It basically provides a surgical roadmap for a complex reconstruction to prevent that reflux.
Okay, moving from one high-risk flaw to another. Colorectal cysts. The sources really stress these. They might be statistically rare in practice.
Yeah, you don't see them every day.
But their clinical importance is huge, again, because of that massive malignancy potential.
That's exactly right. They're important to recognize because they can be subtle. You might have a young patient, maybe with vague right upper quadrant pain, or they might have recurrent episodes of cholangitis, biliary infections or jaundice that aren't easily explained.
But often they're just found by accident.
Very often, yes. An incidental finding on imaging done for something completely different.
Okay, so here's a key diagnostic clue then. If you see the common bile duct dilated, but there's no obvious stone or mass blocking it.
You absolutely have to think about a colorectal cyst. Put it high on your differential diagnosis.
Right. And here's the really sobering part, the risk.
Yeah, this is where it gets really, really serious. The overall lifetime risk of developing cancer within these cysts is tragically high. We're talking 10 to 15%.
Wow.
Let's put that in context for you, the learner. That's a 20 to 30-fold increase compared to the general population.
Okay, that's enormous.
This isn't a risk you just monitor. This is a risk you proactively eliminate if possible. And critically, the risk isn't static. It goes up, often exponentially, as the patient gets older.
And it's not just the usual type of biliary cancer.
No. While the most common cancer is cholangiocarcinoma, CCA, the sources remind us that this chronic inflammatory environment can basically breed diverse and aggressive cancers. Things like anaplastic carcinoma, undifferentiated types, even squamous cell carcinoma have been reported. Complete excision is really non-negotiable for most types of these cysts.
So let's break down that classification. Table 1 in the sources shows management is really dictated by the type of cyst.
Yes, the type is everything. Type 1A is the most common, the one you'll encounter most often, maybe 50 to 85% of cases. This is a cystic dilation affecting the entire extrahepatic biliary tree, so the part outside the liver.
And the treatment for that?
For type 1A, the standard of care is complete excision. You remove the entire dilated segment and then you reconstruct the drainage, typically using what's called a hepatochogenostomy, connecting the liver's main duct to the small intestine.
Okay. Then there's type 3, the colivaca cell, which seems quite different.
It is. Type 3 is much more localized. The dilation is limited just to the part of the common bile duct that's inside the duodenal wall.
So it's contained.
Exactly. Because it's anatomically contained and carries a lower overall malignancy risk compared to types 1, 4, and 5, you can often manage it less invasively. Usually, a procedure called sphincterotomy, where you cut the sphincter muscle during an ERCP, is sufficient.
So the big takeaway from this whole section on developmental problems, PBM, these cysts, is really about cancer risk.
Absolutely. When you're dealing with these developmental biliary pathologies, you're not just treating current symptoms. Often there aren't any. You're actively diffusing a massive ticking cancer time bomb.
Okay, that makes sense. So moving from those rare high-risk developmental failures to something incredibly common, gallstones. This is the condition most people have heard of. But even here, the diagnostics, the risk factors, when to intervene, it's surprisingly complex.
It really is. Gallstones are ubiquitous, but understanding their composition gives us important clues about why they formed. Cholesterol stones are by far the most common type we see, especially in Western countries. They're mostly made of cholesterol monohydrate crystals.
Linked to diet and metabolism.
Often, yes. Issues with cholesterol saturation in the bile, problems with nucleation, how the crystals start forming.
And then you have the pigment stones, which signal something different is going on.
Precisely. Pigment stones are made mainly of calcium bilirubinate. We usually split them into two types. Black pigment stones are typically associated with conditions causing chronic hemolysis, where red blood cells are breaking down too quickly. Think sickle cell disease, thalassemia.
Okay.
Brown pigment stones, on the other hand, they usually point towards biliary spaces, bile not flowing well, and chronic infection within the bile ducts themselves.
Got it. And the risk factors. The list is huge. It goes way beyond the classic 4S mnemonic.
Oh, absolutely.
Yeah.
That mnemonic, fat, fertile, female, 40, is memorable, but it barely scratches the surface.
Yeah.
It highlights the multifactorial nature. You have the well-known ones: older age, female gender, pregnancy, and the postpartum period, obesity, and interestingly, rapid weight loss.
Rapid weight loss, too. Why is that?
When you lose weight very quickly, you mobilize large amounts of cholesterol from fat stores, which can supersaturate the bile. Bariatric surgery patients are a classic example. Then you have specific medical conditions: TPN, total parenteral nutrition, cirrhosis, Crohn's disease.
And medications play a big role, too.
A huge role. Estrogen, oral contraceptives are well known, but also somatostatin analogs, drugs used for neuroendocrine tumors, they inhibit gallbladder motility. The antibiotic ceftriaxone can precipitate in bile. Even older cholesterol drugs like clofibrate were implicated.
So it's a broad net. You always need to ask about systemic disease and medication.
Always. It's essential when working up suspected gallstone disease.
Now let's quickly touch on the terminology for the pain. Our sources stress that biliary colic is actually a misnomer.
Yes, this is a crucial distinction for anyone listening. Colic implies pain that comes and goes, like cramping.
Right, waxing and waning.
But the pain from gallstones, usually felt in the right upper quadrant or the epigastrium, is typically constant. It's a steady, severe pain that lasts for several hours. It usually only resolves when the stone eventually dislodges from the cystic duct or the gallbladder just sort of fatigues.
Okay, constant pain, not colic. And we should also flag a few rare but really dramatic complications where a stone ends up somewhere unusual.
Yeah, these are important to recognize, even if they're rare. You'll see them in case reports or on-board exams. First is Maurice's syndrome. This is where a stone gets stuck in the cystic duct or the gallbladder neck, but it's positioned just right so it externally compresses and obstructs the nearby common hepatic duct.
So the blockage isn't in the main duct, but pushing on it from the outside.
Exactly. Second, gallstone ileus. This is quite dramatic. A large gallstone erodes through the inflamed gallbladder wall. It creates a fistula, an abnormal connection, usually into the duodenum. The stone then travels down the intestine
And gets stuck somewhere.
usually in the narrowest part, the terminal ileum, causing a bowel obstruction, hence ileus.
Wow. Okay, and the third one.
Third, and maybe the most unusual, is Bouvere's syndrome. This is basically a gastric outlet obstruction. It's caused by a gallstone, again, usually entering the duodenum via a fistula, but this time it gets impacted right at the exit of the stomach in the pylorus or duodenum itself.
Okay, all three sound like surgical emergencies.
They absolutely are. Urgent surgical attention is needed for all of them.
Right, so most stones just cause pain or maybe nothing at all. What about removing the gallbladder just in case, prophylactically?
Yeah, this is a common question. The general rule for asymptomatic stones found incidentally that aren't causing problems is basically hands-off. Prophylactic cholecystectomy is generally not recommended for these patients in the general population.
Even if they have other conditions like diabetes or chronic hemolytic anemia?
Correct. Even in those groups, the risk of the surgery itself generally outweighs the relatively small risk of those asymptomatic stones becoming symptomatic in the future.
But there are some very specific exceptions where the risk calculation flips, often because of that malignancy concern we keep coming back to. These are critical to know.
Absolutely critical. These exceptions form a high-risk list where prophylactic removal is recommended. First on the list is the porcelain gallbladder. This is where you see extensive calcium deposits within the gallbladder wall on imaging.
Why is that so bad?
The risk of having a coexisting gallbladder cancer or developing one later is shockingly high at the sources, quote, around 20%. That mandates removal.
20%.
Second, connecting back to our earlier discussion, patients diagnosed with an abnormal pancreatobiliary junction, PBM.
Right, because of that inherent massive risk of gallbladder cancer from the chronic pancreatic juice reflux.
Exactly. Intervention is needed there. Third, we consider patients with gallbladder polyps that are 10 millimeters or larger. We'll detail polyps more later, but size is the key factor driving removal.
Okay, size matters for polyps.
Fourth, Think about patients receiving specific long-term medications, particularly somatostatin analogs. These are used for things like neuroendocrine tumors. These drugs significantly slow down gallbladder emptying, which greatly increases the risk of forming stones and developing cholecystitis. So removal is often advised.
Makes sense. Preventative.
And finally, patients undergoing bariatric surgery. That rapid, significant weight loss post-surgery is a major trigger for gallstone formation. While you can use a medication called ursodiol to try and prevent stones, many centers just opt for concurrent cholecystectomy during the bariatric procedure itself to avoid future problems.
So a clear set of specific indications where you do take out an asymptomatic gallbladder.
Okay, so now the stones aren't just in the gallbladder. They've escaped into the main pipe, the common bile duct, or CBD. This is choledochal lithiasis. This immediately escalates the situation. A stone blocking the CBD can cause jaundice, severe pain, and more dangerously, ascending cholangitis, a serious infection, or pancreatitis.
So the workup needs to be efficient and accurate. Standard first steps are ultrasound and liver function tests. LFTs, right?
Yes, those are your initial tools. But the sources make a really important point. In older patients presenting with obstructive jaundice, you must get cross-sectional imaging like a CT or MRM-RCP.
Why the extra steps specifically in older patients?
Because in an older individual with jaundice and a blocked duct, you have to strongly consider and rule out an underlying biliary malignancy as the cause of the obstruction, not just assume it's a benign stone.
That imaging helps differentiate a stone from something more sinister like a tumor.
Precisely. Now, to streamline care and, importantly, to avoid unnecessary high-risk procedures, the American Society for Gastrointestinal Endoscopy, ASGE, published guidelines in 2019. Table 2 in the sources. These guidelines provide a fantastic system for predicting the probability of having CBD stones before the patient goes for gallbladder surgery, cholecystectomy.
And this helps decide who needs an ERCP beforehand.
Exactly. ERCP, endoscopic retrograde cholangiopancreatography, is the procedure we use to remove CBD stones, but it carries risks, like pancreatitis. So you only want to do it if really necessary.
Okay, let's walk through this ASGE triage system. First, the high probability group.
Right. If a patient falls into the high probability category, the recommendation is to proceed directly to a preoperative ERCP to clear the duct before gallbladder surgery.
What puts them in that high probability bucket? The predictors must be strong.
They have to be very strong, basically confirming a stone is there. The criteria are, 1, you actually see a CBD stone on an imaging study like ultrasound or MRCP. That's definitive.
Okay.
2, the patient has a clinical diagnosis of acute cholangitis fever, jaundice, abdominal pain. That implies an infected, obstructed duct.
Right, infection needs drainage.
Or 3, and this is a specific combination, both a significantly elevated total bilirubin level,
Wow.
greater than 4 milli-GDL, and a dilated common bile duct seen on imaging.
That specific combo really points to a blockage.
It does. That combination strongly suggests an obstructing stone that needs removal via ERCP, pronto.
Okay, what about the middle ground? The intermediate probability patients. They aren't clear-cut.
Exactly. These patients have some concerning signs, but not enough to justify immediate ERCP. They're too high risk just to go straight to surgery, but not definitive enough for upfront ERCP. For these intermediate risk patients, you need more information first. The guidelines recommend further non-invasive imaging.
Like what?
Like endoscopic ultrasound, EUS, which is very sensitive for small stones, or magnetic resonance cholangiopancreatography, MRCP. Another option is to plan for an intraoperative cholangiogram, IOC, where they inject dye into the bile ducts during the gallbladder surgery itself to check for stones.
And what are the predictors that land someone in this intermediate group?
The predictors are things like abnormal liver function tests that don't meet that high bilirubin threshold 4, or being older than 55, or having a dilated CBD on imaging without the high bilirubin.
And the definition of dilated here is specific, right? It depends on whether the gallbladder is still there.
Yes, that's a key detail. A CBD is considered dilated if it's greater than 6 millimeters with an intact gallbladder. But if the patient has already had their gallbladder removed, post-cholecystectomy, the normal duct diameter increases slightly, so the cutoff for dilation becomes greater than 8 millimeters.
Got it. So 6 millimeters or 8 millimeters depending. And finally, the low probability group.
This is the easiest group. If the patient has none of the high or intermediate predictors, normal LFTs, not elderly, normal CBD diameter, they are considered low probability. For these patients, the recommendation is to proceed directly to cholecystectomy without needing any preoperative ERCP or further biliary investigation.
So this structured approach really helps target ERCP to those who need it most and avoids unnecessary risk for others.
Precisely. It's a cornerstone of modern biliary management, balancing diagnostic certainty with procedural risk. Now let's talk about a really common scenario we encounter now with widespread imaging. Finding a dilated bile duct, often just incidentally on a CT or ultrasound done for unrelated reasons. This finding immediately raises a crucial question. Is this duct dilated because there's a genuine obstruction we need to treat urgently? Or is it dilated due to some benign, non-obstructive cause?
Yeah, that must be a common diagnostic headache. A dilated duct sounds alarming, but it might not actually be dangerous in the moment.
Exactly. It causes anxiety for everyone involved, but we need to use our best tools to distinguish true pathology from just architectural variation or post-pathology changes. This is a real gray area. Hashtag tag 3.1. Understanding common bile duct dilatation.
Okay, first things first, let's define our terms. When do we officially call a common bile duct dilated?
The definitions are fairly well established, although they do adjust based on the patient's history and age. Generally, we use 6 millimeters as the upper limit of normal diameter in the general adult population.
6 millimeters.
That cutoff tends to increase with age. For patients aged 60 or older, we often accept up to 8 millimeters as potentially normal.
Okay, age makes a difference.
And for patients who've had their gallbladder removed previously post-cholecystectomy, the duct often dilates slightly over time, maybe due to changes in sphincter function. So for them, the upper limit is often considered 8 to 10 millimeters.
There used to be that old rule of thumb, right? Adding 1 millimeter per decade after 60?
Yes, that was the traditional teaching. But more recent studies suggest the increase with age is probably smaller, maybe closer to 0.3 to 0.7 millimeters per decade, not a full millimeter. So we need to be a bit cautious with that old rule.
Good to know. Now, what are the common reasons a duct might be dilated without there being an active mechanical blockage right now?
This list of non-obstructive causes is really important to keep in mind. The most common is probably prior cholecystectomy. Advanced age itself is a factor. Chronic use of opioid medications, they can cause spasm of the sphincter of Oddi, leading to backup and dilation.
Oh, interesting. Opiates.
Yeah. Then there are conditions like biliary dyskinesia, which is a motility disorder. Even chronic inflammation from previous gallbladder disease, chronic cholecystitis, can sometimes lead to duct changes. And importantly, if a patient previously had an obstructing stone that eventually passed, the duct might remain permanently dilated. We also see this inherent dilution in certain choledochal cyst types, like types 1 and 4, even without current obstruction.
Okay, so quite a few benign possibilities. So let's say we find this incidentally dilated duct. The patient feels fine, their liver tests are normal. What's the approach, and what's the absolute key rule about using ERCP here?
The crucial rule, and this is paramount for every learner to remember, is that ERCP should never be performed solely for diagnostic purposes in a patient with just a dilated duct, but no clear signs or symptoms of obstruction.
Why not?
The risks associated with ERCP, particularly post-ERCP pancreatitis, which can be severe, are simply too high to justify using it just to get a look around when there's no clear therapeutic target. The risk outweighs the potential diagnostic benefit in that scenario.
So diagnostic ERCP for isolated dilation is out. What do we do?
We turn to our high-resolution, non-invasive imaging tools. The workup should include endoscopic ultrasound, EUS, and/or MRI with MRCP. The goal of these tests is to meticulously look for a subtle obstructive lesion that might have been missed on the initial ultrasound, things like a tiny stone, sludge, or perhaps an early small tumor.
Especially if there are other subtle clues.
Exactly. This becomes particularly vital if you see any secondary signs suggesting obstruction, even if the LFTs are normal.
Like the double duct sign. That sounds ominous.
It is a very ominous sign. The double duct sign means you see simultaneous dilation of both the common bile duct and the pancreatic duct on imaging. This strongly suggests the blockage is low down, near the ampulla where the ducts meet, and it's highly suspicious for a mass there, often a pancreatic head cancer or an ampullary cancer.
Okay, big red flag. What about the Courvoisier sign?
Courvoisier sign is a clinical finding. A palpable, non-tender distended gallbladder in a jaundiced patient. This also strongly suggests a malignant obstruction distally, because a gallbladder chronically obstructed by a slow-growing tumor distends gradually without becoming acutely inflamed and tender like it often does with stones.
Got it. So if the EUS or MRCP comes back clean, no stones, no mass, nothing suspicious.
If that initial high-resolution workup is negative, then the diagnostic evaluation for the isolated dilation is essentially complete. You can reassure the patient. It's often reasonable to recommend follow-up imaging, maybe in 3 to 6 months, just to ensure stability. If the dilation remains stable over a period of, say, more than 6 months, the likelihood of an underlying malignancy being missed is extremely low. Hashtag 3.2 sphincter of Oddi dysfunction. SOD.
Okay, now we wade into perhaps the most controversial and complex area in biliary diagnostics, sphincter of Oddi dysfunction, or SOD. This is often suspected in patients, especially those who've had their gallbladder out who continue to have biliary-type pain, or patients with recurrent pancreatitis where no other cause is found.
Yes, SOD has been a diagnostic and therapeutic quagmire for years. The terminology and classification have actually evolved significantly, largely driven by, well, disappointing clinical trial results.
How has the classification changed? There used to be types 1, 2, and 3, right?
That's right. The old system, based on the Milwaukee classification, had 3 types. What was type 1 SOD is now generally referred to as sphincter of Oddi stenosis. This implies a definite mechanical obstruction at the sphincter. These patients have biliary pain plus clear objective evidence, elevated liver or pancreatic enzymes, and duct dilation on imaging. Often, ERCP confirms delayed drainage of contrast.
And treatment works for them.
Yes, for true stenosis, type 1, sphincterotomy, cutting the sphincter muscle during ERCP is generally effective.
Okay, so type 1 is relatively clear. What about type 2?
Type 2 is always the ambiguous group. These patients have the characteristic biliary pain, but they only have one of the objective findings, either the enzyme elevation or the duct dilation, but not both. This category is now often called suspected functional biliary sphincter disorder. The benefit of invasive treatment here has been highly debated for years.
And then type 3, what happened there?
Type 3 SOD, which was defined as patients having only the biliary type pain with no objective abnormalities, normal enzymes, normal ducts, has essentially been abandoned as a concept needing sphincterotomy.
Abandoned? Why?
This was a direct result of the EPISOD trial. It was a landmark randomized controlled trial. It definitively showed that performing a sphincterotomy in these type 3 patients provided absolutely no more benefit than undergoing a sham procedure and ERCP without the cut.
So all risk, no benefit.
Precisely. All risk, no proven benefit. These patients are now generally considered to have a functional abdominal pain syndrome, not a primary sphincter problem treatable with cutting.
Wow, that trial really changed practice. And this theme of risk versus uncertain benefit seems to carry through even for the type 2 patients, based on the more recent RESPOND study.
Yes, the RESPOND study adds another layer of caution. This was a cohort study looking specifically at patients with suspected SOD, mostly fitting type 2 criteria, who also had idiopathic recurrent pancreatitis. The results were, well, mixed and hard to interpret. On one hand, nearly 60% of the patients reported clinical improvement after undergoing sphincterotomy.
That sounds positive.
It sounds positive, but here's the catch. It was a single-arm study. There was no control group, no sham procedure comparison, so we simply cannot rule out a significant contribution from the placebo effect or just the natural history of the condition. The patient expected the procedure to help, they got it, and they felt better. Did the cut itself help? We don't know for sure from this study design.
So the risks were definitely real.
The risks were very real. The rate of post-ERCP pancreatitis in the RESPOND study was 11%.
11%, that's high.
That's a very significant complication rate, especially when the benefit is uncertain. And critically, the study also found that performing sphincterotomy did not actually reduce the risk of future episodes of acute pancreatitis. Patients still had recurrences. 17.4% had new episodes. 30.9% had recurrences if they'd had it before.
So the procedure didn't even achieve that potential goal reliably.
Correct. So the takeaway from EPISOD and RESPOND is profound. It has drastically shifted practice. Most gastroenterologists are now extremely cautious about offering ERCP and sphincterotomy for suspected functional biliary or pancreatic sphincter disorders. You have to have a very clear discussion with the patient, explicitly stating the uncertain benefits and the very real risk of procedure-related pancreatitis. It's a high-risk, questionable reward scenario for many of these patients.
Okay, let's pivot now and focus specifically on malignancies within the biliary system. We've touched on the risk with PBM and cysts. Let's start with something often found incidentally that causes a lot of patient anxiety: gallbladder polyps. We know chronic inflammation is a driver, but with polyps, it seems size is the main dictator of action.
That's right. And the first thing to emphasize to reassure patients is that the vast majority of gallbladder polyps are completely benign. They're not cancerous, they're not precancerous. Most are either cholesterolosis, just the cholesterol deposit sticking to the gallbladder wall, or adenomyomatosis, which is a benign thickening and outpouching of the gallbladder wall lining. Neither is malignant.
Okay, so most are harmless, but we're laser focused on that small percentage that could be dangerous, and the key threshold seems to be 10 millimeters.
Exactly. 10 millimeters is the critical size cutoff. The risk of malignancy, or of the polyp representing an early cancer, increases significantly once it reaches 10 millimeters 1 centimeter or larger. For polyps of that size, assuming the patient is reasonably fit for surgery, cholecystectomy is generally recommended. That's the clear line in the sand.
Simple F. But what about the smaller ones? Polyps between, say, 5 and 9 millimeters. The guidelines seem much more nuanced there.
They are. For polyps in that intermediate size range, typically 6 to 9 millimeters, the decision about surgery versus surveillance depends on integrating other risk factors. Cholecystectomy is generally recommended for these intermediate size polyps if the patient also has specific risk factors for gallbladder cancer.
What are those risk factors?
The main ones are age over 60, a concurrent diagnosis of primary sclerosing cholangitis, PSC. Being of Asian ethnicity, gallbladder cancer is more common in some Asian populations. Or if the polyp itself looks suspicious on ultrasound, like being sessile, flat instead of pedunculated on a stalk, or if there's associated gallbladder wall thickening greater than 4 millimeters.
So size plus risk factors equals surgery in that 6-9 millimeter range.
Correct. Now, what if the polyp is small, say 5 millimeters or less, and the patient has none of those risk factors?
No follow-up needed.
Generally, yes. For polyps 5 millimeters or less without risk factors, the risk is considered negligible, and typically no further follow-up imaging is required.
But what if they're small but do have risk factors, or they're in that 6-9 millimeter range without risk factors and you choose surveillance? How is that done?
For those smaller polyps that warrant monitoring, there's a structured surveillance protocol recommended by Joint Society guidelines. Typically, it involves follow-up ultrasounds at 6 months, 12 months, and then 24 months.
Looking for growth.
Exactly. You're monitoring for any significant increase in size or changes in appearance. If the polyp disappears, or if it remains stable in size over that 2-year surveillance period, the monitoring can generally start. The risk of it becoming malignant after being stable for 2 years is considered very low. #tag 4.2 cholangiocarcinoma, CCA. Okay, moving from polyps, which are usually benign, to the primary cancer of the bile ducts themselves. Cholangiocarcinoma, or CCA. This is often the feared endpoint of the chronic inflammatory conditions we've been discussing.
Right. Besides the developmental anomalies like cysts and PBM, what are the major acquired risk factors we need to recognize for CCA?
Well, in Western countries, perhaps the single strongest association is with primary sclerosing cholangitis, PSC. Patients with PSC have diffuse inflammation and scarring of their bile ducts. Their cumulative incidence of developing CCA is significant, around 9% after having PSC for 10 years. It's a major complication we screen for.
9%. Okay, what else?
Other important risks include hepatolithiasis, having stones actually within the bile ducts inside the liver, Caroli disease, which is another type of congenital cystic dilation of the intrahepatic ducts, and then globally, particularly in parts of Southeast Asia, chronic infection with liver flukes parasites like Opisthoratus viverrini and Colorinus sinensis is a major cause due to the intense, prolonged inflammation they induce.
Any genetic links?
Yes. There's also an association with certain inherited cancer syndromes, most notably Lynch syndrome.
Location seems really key for CCA, determining prognosis and treatment. The sources say most are extrahepatic.
That's right. About 80% of cholangiocarcinomas arise in the bile ducts outside the liver, extrahepatic. And within that group, the majority, maybe 70% of the extrahepatic ones, occur right at the hilum of the liver, where the main right and left hepatic ducts join to form the common hepatic duct.
These are the Klatskin tumors.
Exactly. Peripheral CCA, or Klatskin tumors. They are notoriously difficult to manage because they're right at that critical junction involving major blood vessels like the hepatic artery and portal vein. Distal CCA, arising lower down in the common bile duct, below where the cystic duct joins, is somewhat less common but often more amenable to surgical resection, usually via a Whipple procedure, pancreaticoduodenectomy.
Let's talk about diagnosis. The tumor marker CA19-9 is often ordered. How useful is it really?
CA19-9. It's useful, but it comes with major caveats. Its specificity, meaning its ability to correctly identify patients without cancer, suffers badly if there's active inflammation or bile duct obstruction, cholestasis.
So inflammation or blockage messes up the test.
Big time. The sources confirm this. While a very high CA19-9 level, say over 180 FLM, is quite specific for malignancy, the commonly used lower cutoff, around 37 ml, becomes really unreliable if the patient has concurrent cholangitis. In the presence of cholangitis, the specificity of that lower cutoff plummets down to maybe 42%. So a mildly elevated CA19-9 in someone with active biliary inflammation or obstruction doesn't necessarily mean cancer. You often need to treat the infection or obstruction and then recheck the level.
Okay, that's a critical point. Yeah. And getting actual tissue confirmation, a biopsy from a biliary stricture, that's notoriously difficult, isn't it?
It's one of the biggest diagnostic challenges in gastroenterology. The ducts are narrow, tumors can be deep within the wall, and often the cancerous cells are scarce on the surface. Standard techniques during ERCP, like brushing the stricture, brush cytology, or taking tiny bites, forceps biopsy, have historically had relatively low sensitivity when used alone.
So you need to combine methods.
Yes. The concept of multimodal tissue acquisition is key. Combining brushing and forceps biopsy significantly improves the diagnostic yield. Together, they can achieve a sensitivity closer to 86%, according to the sources.
And newer technologies are improving this further, like directly visualizing the duct.
Absolutely. The advent of digital single-operator cholangioscopy, DSOC, has been a major step forward. This involves passing a tiny camera directly into the bile duct during ERCP. It allows us to actually see the stricture, characterize its appearance, and then take biopsies under direct visualization, targeting the most suspicious areas.
And that improves accuracy.
Significantly. Studies cited show DSOC with targeted biopsy boosted the sensitivity for diagnosing indeterminate Hiller strictures up to around 68.6%, compared to only 21.4% for standard brushing alone in the same difficult group. Direct visualization is becoming essential for these challenging cases.
Now, a really important caution, especially for learners, regarding using endoscopic ultrasound, EUS, with fine needle aspiration, FNA, near the primary tumor, particularly for Hiller CCA.
Yes, this is a potential pitfall with serious consequences. EUS FNA is very useful for sampling enlarged lymph nodes near the bile duct, periportal nodes, to help stage the cancer.
But don't stick the needle in the main tumor itself.
Exactly. You should strictly avoid performing EUS FNA on the primary Hiller tumor mass itself. The major concern is the risk of disease dissemination, potentially seeding cancer cells along the needle track or into the peritoneal cavity.
And why is that so critical?
Because if the patient might otherwise be a candidate for potentially curative treatment like liver transplantation, which is sometimes considered for unresectable Hiller CCA, tumor seeding from an FNA can immediately render them ineligible for transplant. It can inadvertently take away their best chance for long-term survival. So sample the nodes, but avoid the primary Hiller mass with EUS FNA.
That's a huge point. Speaking of transplant, for those highly selected patients with Hiller CCA that can't be surgically removed up front, there's a specific aggressive protocol that shows promise.
Yes, there is. For carefully selected patients with unresectable Hiller CCA confined to the liver and regional nodes, protocols involving intense neoadjuvant chemoradiation, chemo and radiation before surgery, followed by liver transplantation have been developed, pioneered notably at the Mayo Clinic. This is a very demanding treatment path, but the results in these highly selected candidates have been quite remarkable, with reported 5-year recurrence-free survival rates around 65%. It represents a major advance for a previously dismal prognosis.
Okay, let's transition to our final section. The complications that can arise after major interventions, focusing particularly on the most complex scenario, the post-liver transplant patient. Managing the bile ducts in a transplant recipient sounds incredibly challenging, balancing immunosuppression, blood supply issues, and surgical technique. Hashtag tagged 5.1, post-liver transplant biliary complications.
It is indeed one of the Achilles heels of liver transplantation. The biliary anastomosis, where the donor bile duct is connected to the recipient's system, is a common site for problems. Surgeons use two main types of reconstruction. There's the duct-to-duct anastomosis, where the donor's common bile duct is sewn directly to the recipient's common bile duct. The alternative is a Roux-en-Y kuldaco-jejunostomy. Here, the donor bile duct is connected instead to a loop of the recipient's small intestine, jejunum, that's brought up.
Is one preferred over the other?
The Roux-en-Y is often preferred specifically in patients who are receiving a transplant because they had primary sclerosing cholangitis, PSC. The idea is to bypass the potentially diseased recipient duct system entirely, hopefully reducing the risk of PSC recurring in the graft's biliary tree near the anastomosis.
And the source of the liver graft matters too. Living donor versus deceased donor.
It definitely impacts the risk profile. Biliary complications, mainly strictures, narrowings, and leaks, are unfortunately quite common after any liver transplant, but the rates are generally higher in patients who receive a graft from a living donor, LDLT, compared to a deceased donor.
Why is that?
It primarily relates to the anatomy and technical aspects. In LDLT, especially with right lobe grafts, the bile ducts being connected are often smaller in diameter, and the vascular supply can be more tenuous, making the anastomosis technically more challenging and potentially more prone to ischemia, lack of blood flow, or scarring leading to strictures. Hashtag 5.2 biliary strictures.
Okay, let's talk about those strictures. They seem to fall into two main categories based on location, and that location really matters for prognosis. Let's start with a more common type. Anastomotic strictures.
Right. Anastomotic strictures account for the majority, maybe around 80%, of all post-transplant biliary strictures. As the name implies, they occur right at the surgical connection site. They typically present relatively early, usually within the first year after transplant. They're generally short, localized narrowings caused by scarring during the healing process. Sometimes a prior bile leak at the site can contribute to the fibrosis.
And the good news is these are usually treatable.
Yes, the treatment for anastomotic strictures is usually highly effective and relies on endostatic therapy via ERCP. The cornerstone is serial balloon dilation. We pass balloons through the endoscope and inflate them across the stricture, typically up to 6 or 8 millimeters in diameter, to stretch it open. This is usually followed by placing multiple plastic stents across the stricture to keep it open while it heals remodeled.
Does it take multiple procedures?
Often, yes. Patients typically need to undergo a series of ERCPs, maybe 3 to 5 sessions, usually spaced every few months, for repeated dilation and stent exchanges. But the long-term prognosis for these isolated anastomotic strictures is generally very good, with success rates reported between 70 and 100%.
Okay, that sounds manageable. But the other type, non-anastomotic strictures, NAS, sounds much more serious.
They are. NAS account for the other 20% or so, and they carry a much graver prognosis. These strictures occur away from the surgical anastomosis, typically affecting the ducts higher up at the hilum or even diffusely throughout the intrahepatic ducts within the liver graft.
And the causes are different too, not just surgical scarring.
Right. NAS usually point to a more widespread injury to the biliary tree within the graft. The main risk factors are ischemia, most commonly due to thrombosis, clotting, of the hepatic artery supplying the graft. This often presents early. Or immunologic problems. Immunologic causes can include ABO blood group incompatibility between donor and recipient, or recurrence of the original disease like PSC in the graft. These often present later.
So what does this mean for the patient and the transplanted liver long term?
Unfortunately, NAS are extremely difficult to treat effectively, whether endoscopically or surgically. The underlying damage to the duct lining from ischemia or immune attack is often irreversible. Despite treatment attempts, the prognosis is often poor. The sources state that up to 46% of patients with NAS eventually develop graft failure, and around 30% may ultimately require retransplantation. It's a major cause of late graft loss. Hashtag 5.3 bile leaks.
All right, the other major biliary complication after transplant and also after other procedures is a bile leak. These seem quite common even after routine gallbladder surgery.
That's right. Bile leaks are actually the most frequent complication following a standard laparoscopic cholecystectomy, with reported rates between 0.5% and 2.5%. Usually the leak comes from the cystic duct stump where the gallbladder was clipped or tied off if the closure is insecure, or sometimes from small aberrant ducts called ducts of Luschka that drain directly from the liver surface into the gallbladder bed and might be transected during dissection.
And they happen post-transplant too.
Yes, significantly more often post-transplant, with rates anywhere from 2% up to 25% reported in various series, often occurring at the biliary anastomosis. They can also happen after significant liver trauma.
How do you confirm a bile leak definitively?
Well, if the patient has a surgical drain still in place after their surgery, and the fluid coming out looks like bile, greenish-brown, that's pretty definitive. That's a bilious drain output.
What if there's no drain?
For non-invasive diagnosis, a nuclear medicine scan called a HID scan, hepatobiliary immunodiacetic acid scan, is very good. It involves injecting a tracer that's taken up by the liver and excreted into the bile. You can then watch under a gamma camera to see if the tracer leaks out of the biliary tree. Functional MRI using a contrast agent like Eovist, which is also excreted in bile, can sometimes help pinpoint the exact site of the leak non-invasively.
And ERCP plays a role here too.
Yes, ERCP is often used both for definitive diagnosis. You inject contrast dye directly into the bile duct and look for extravasation, MISO, and increasator, and crucially as the primary treatment.
Finally, James Toch, DN.
It's a push medicine, meaning seeing where it's leaking.
Ah, apologies. Yes, exactly. Seeing where the contrast leaks out confirms the diagnosis and location during the ERCP.
Okay. And how does ERCP treat the leak? What's the principle?
The cornerstone of therapy for most bile leaks is ERCP with sphincterotomy and placement of a plastic stent across the ampulla, often bridging the leak site if possible.
Why the sphincterotomy? How does cutting the sphincter help a leak?
The sphincterotomy is key. By cutting the sphincter muscle at the opening of the bile duct into the duodenum, you significantly lower the pressure gradient, the resistance to bile flow out of the duct system. This encourages bile to preferentially flow down the path of least resistance through the ampulla and past the stent rather than flowing out through the hole, the leak site. It effectively diverts bile away from the leak.
Reducing pressure at the leak site allows it to heal. Exactly. By reducing the pressure and diverting flow, you allow the leak site to seal over and heal, which usually happens within about 6 to 8 weeks. The success rate for endoscopic management of bile leaks using this principle is very high, often exceeding 90%. Figure 8 in the source material illustrates this beautifully. #tag outro.
Wow. Okay, so we've covered a huge amount of ground. We've mapped the biliary system's architecture. We've navigated the complexities of those developmental anomalies like PBM and cysts with their really high malignant potential. We dissected the precise diagnostic stratification needed for common gallstones and CBD stones using the ASGE guidelines. And we examined those difficult gray areas like the incidentally dilated duct and the controversies around functional pain and SOD.
We did. And we looked at malignancy recognizing high-risk polyps, the challenges in diagnosing cholangiocarcinoma, and the critical importance of avoiding missteps like FNAing a primary Hiller tumor. And finally, we tackled the high-stakes world of post-transplant biliary complications, the treatable anastomotic strictures versus the much more ominous non-anastomotic ones, and the generally effective management of bile leaks.
Thinking back over this entire deep dive, what really stands out to you, particularly for the learner listening, is perhaps that delicate balance we kept seeing between diagnosis and intervention, especially with high-risk procedures like ERCP.
I think that's exactly right. What stands out is how modern biliary management constantly forces us to weigh potential benefits against very real risks. We saw how the gold standard for diagnosing something critical like cholangiocarcinoma still relies on getting actual tissue, often needing multimodal approaches, because biomarkers like CA19-9 just aren't perfect, especially with inflammation. And conversely, we saw how a highly valuable therapeutic tool like ERCP carries significant risks. That 11% pancreatitis rate in the RESPOND study for treating functional disorders is a stark reminder. You don't undertake it lightly.
This critical assessment of risk versus benefit seems to be the core principle guiding almost every decision point we discussed.
Precisely. And this material really highlights how much of modern medicine involves dealing with asymptomatic findings or equivocal test results, the incidentally dilated bile duct, the patient with suspected functional sphincter issues where objective evidence is minimal. We know invasive procedures like ERCP carry significant risks. So the final provocative thought I'd leave you, the learner, with is this. Given these high rates of post-procedural complications and the limited or unproven benefit of invasive therapies in conditions like type 2 SOD or for purely diagnostic exploration, how much further do our non-invasive high-resolution imaging techniques like EUS and MRCP need to progress? How much better do they need to get before we can confidently define a patient population where the risks of any invasive diagnostic or therapeutic endoscopy clearly, unequivocally outweigh any potential benefit? This ongoing critical assessment, this constant reevaluation of balancing diagnostic yield against procedural hazard, refining who truly needs intervention and who can be safely managed non-invasively, that really is the future of navigating the complexities of the biliary tract.